All right, good afternoon. As we get our attendees, everyone's getting into the room here. Welcome, everyone. Just going to give a moment for everyone to get into our room. Hope everyone had a good holiday weekend. I know those in healthcare sometimes do work on the holiday weekends, so appreciate your service for that. While the rest of you are all getting into the room, I'm gonna go ahead and start with just some of my intro slides so we can get moving on today. We got a lot of information that Dr. Meg is going to be going over. So we'll go ahead and get started here. Hello, everyone. My name is Melanie Escher, and I'm with the Arizona Telemedicine Program in the Southwest Telehealth Resource Center. Welcome to our webinar series today. We respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The Southwest Telehealth Resource Center represents Colorado, Arizona, New Mexico, Nevada, and the Four Corners region with a combined total of 72 recognized tribes. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. So a few little tips. When you joined our webinar, your phone or your computer microphone were muted. We will be reserving time for question and answers. You can use the chat function. Anywhere along the presentation, if you have a question, please by all means go ahead and put it into the chat, and we will address that when we're ready. There will be a post-webinar evaluation. It will populate in a URL window behind this webinar that you are in. Please go ahead and do that. There's CME credit available for the live presentation. It is being recorded. You can view this later, but there is no CME credit for the recorded version. I will put this information in an email to everybody. The continuing education information, the outcome objectives, accreditation statement, disclosure statements. There is an attendance tracking code for the CMEs that the university uses with the Cloud CME program. I'll have more information on that in my thank you email to everybody. And this information was sent out in the registration form, so I don't need to read through it right now. And I believe Dr. Mega will be going over those objectives as well. Our standard disclaimer. I don't need to read that. You can take a look at that. We'll continue on again. Please be sure to check our website for upcoming webinars and events. That's www.telemedicine.arizona.edu. And again, your opinion is valuable to us. Please do the evaluation, and there's a space on there for you to tell us what else you might like to hear about so that we can get other information that our audience wants. This is how we build our webinar different options available. And again, the CME credit, there's a number in the survey that you will text in for the Cloud CME program. If you have any questions, you can reach out to me on that as well. So today's program is called Treatment of Substance Use Disorders in Primary Care. And first I'm going to introduce Ernestine Nassing. Oh, wait a minute. I don't want to butcher that. Hold on a second, Ernestine. Hold on. Nassing Atua.
Yes.
That's okay. Good. Thank you. So she's the educational coordinator with the newest American Indian Health Arizona Health Education Center. So Ernestine, would you like to talk a little bit about that? And then I'll introduce our speaker today.
Yeah, thank you. Hi, everyone. Thank you, Melanie and Dr. Mega. The American Indian Health AHEC is absolutely grateful for the Arizona Telemedicine and Southwest Telehealth Resource Center. The American Indian Health AHEC is in its first operational year, so we appreciate this partnership as we grow our programming. I'll just give a short summary about the American Indian Health AHEC. The American Indian Health AHEC is one of 6 area health education centers in Arizona. The American Indian Health AHEC works towards enhancing tribal healthcare systems and strengthening current workforce strategies and solutions. We're involved in a variety of activities, including youth healthcare career exploration programs, community-based experiential training. We have the AHEC Scholars community immersions, and then we also have events like today, the continuing education for healthcare professionals. Our team is made up of Jeff Axtell, he's our director, and then we also have Tashina Mashane, who is our youth program coordinator, and myself. And thank you everyone for joining us today.
Great, thank you, Ernestine. I get to introduce Dr. Mega, who's a family medicine specialist with the White River Indian Health Services. He's board certified physician in family medicine and addiction medicine. And in 2014, he completed his residency in family medicine at the Contra Costa Family Medicine Program in Northern California. Subsequently worked full-time in the ER at the Contra Costa Regional Medical Center and helped to pilot novel California Bridge program that deployed substance use navigators to help patients in the ER address needs related to substance use. In 2021, he joined the White River Indian Health Service Hospital in White River, Arizona, serving the White Mountain Apache tribe, and he currently works in the ER at White River and started a weekly bridge clinic, which addresses the needs of patients with substance use disorders. So without any further ado here, I'm going to go ahead and stop my screen share and we'll get Dr. Mega to go ahead and get his up and he will go ahead and continue with the presentation. Thank you again for joining us.
Great, thank you. I'm excited to be here. I have a lot to talk about today. I tried to make this practical for people and kind of in the way that I perceive these visits with patients and making them easy and practical for patients as well. So I'll get started. I titled this Treatment of Substance Use Disorders in Primary Care, but really I want this to just be for anyone who's providing care in a clinic setting or even an inpatient or the emergency department where we do a lot of that here in White River. But anyone who's seeing patients in clinic, this applies to. I don't have any conflicts of interest, and I just wanted to say that I will be talking about a fair amount of off-label use of medications. The educational objectives, are I'm going to talk a little bit about the prevalence of substance use disorders and some of the disparities in the American Indian Native Alaskan populations, review some of the tools that we use for screening for substance use disorders in primary care, and list some ways to expand treatment options for treating SUDs in primary care, as well as some practical office-based medication-assisted treatment options for various SUDs. So you got a little bio about me. I wasn't sure if that was going to happen, so just a little bit of background. So as Melanie said, I did my residency in California, and I ended up working full-time in an emergency department for a little while after that, and really found I was working in this setting where I wasn't addressing a lot of the needs of the patients that were coming in. And I ended up taking a position where I was overseeing the healthcare for the homeless program in our county. And just through that process, it found that I needed to be an expert in providing care for patients with substance use disorders. And so did a lot of kind of novel approaches to helping people access care for various different substance use disorders, particularly opioid use disorder in that setting. And then I also spent some time working in our county jail. I worked in a prison reentry program, and all of those, are settings where patients just through the nature of how they ended up in my office were had history of substance use disorder. And now I work in White River. I always tell people I'm about 3 o'clock on the Arizona map. And I work at the IHS hospital here, mostly in the emergency department, but I do 25% time at our Bridge clinic, which we'll talk a little bit about later. But basically, it's like a place where I see predominantly patients with substance use disorders. So just kind of looking broadly at substance use disorders in the United States, and this includes alcohol and other drugs. 17% of people in the United States are identified as having a substance use disorder. It's a huge percentage. And so we're seeing patients with this every day in clinic. And if we're not asking the right questions. I think we all probably have someone adjacent to us in our lives who's at some point suffered from substance use disorders, if not ourselves. So this is, I think, a relevant topic for anyone. And these are just people with a diagnosis of a substance use disorder. This isn't like unhealthy use. So it's a high percentage of people with a clinical diagnosis. Let's see here, sorry. And then if we kind of look at the sequela of some of this, so in alcohol in particular, and that's the predominant substance that the population I take care of struggles with. I think it's really understated or at least I didn't recognize how significant the impact of alcohol was to people. You know, there's a very direct correlation between overdosing on an opioid and death, but the deaths associated to alcohol are often protracted, chronic liver disease, other sequelae of alcohol, or they're alcohol-related injuries like motor vehicle accidents. And so I just wanted to highlight, you know, we hear a lot about opioid-related deaths in the United States, and that's a very significant number, but about double as many people die from alcohol. And it's a slow burn in a lot of cases, but it's one we have a lot of opportunities to intervene on. If we look at substance use disorders by race, very disproportionately, American Indians, Native Alaskans suffer from substance use disorder. And that's across all substances, actually. I think we hear a lot about alcohol, but I've seen more marijuana use here working in White River than I've ever seen across the population. And so anyone working in Arizona is going to be likely working with members of tribal nations. And I think just, you know, making sure we're screening and helping people get access to the care they need is important, and recognizing that there's a disproportionate amount of folks suffering with substance use disorders. And then if we look at the negative sequela of these substance use disorders in that population, people of American Indian, Alaskan Native backgrounds are much more likely to die from alcohol-related, or in particular, causes, 5 times more than the closest other racial demographic. And I see this every day, 30-year-olds with cirrhosis, people in their 20s developing like severe alcoholic hepatitis. And so again, anything we can do to help people reduce their use or get support is really important, especially earlier on when people are in their teens or early 20s. Just a reminder, opioid use disorder and deaths from opioids, particularly fentanyl and synthetic opioids, continues to be a huge problem in the United States. You know, this graph has been increasing over the past 9 to 10 years. We saw like a little bit of a plateau in the last year. But what's interesting is if you look at the map on the right, there's been a decrease in the East Coast, Midwest, in places in Southeast where we've kind of historically heard about this being a problem, and a big increase in the West. And we don't really have an opioid use disorder problem here. Like, thankfully, there's not a lot of fentanyl. It's not the predominant thing that I'm treating, but I think it's coming, and I think it'll be really scary when we start combining a lot of fentanyl with other specifically alcohol. And so something to start making sure, if you're not already, asking patients about or being aware of. And then when I started my training in California, methamphetamine use disorder was the main thing that I was seeing. And we still see that a lot here. It's not as prevalent, but there definitely is a lot of it. And I think it's maybe another understated substance that contributes to deaths that we're not aware of, particularly when it's combined with opioids. And I think, there's a lot of situations where people get a tainted supply of their methamphetamine that has fentanyl in it, and those patients are generally opioid naive. So just another thing to think about, like asking your patients about making sure you're offering resources for harm reduction, and we can talk a little bit about that after in a bit. And then I brought up the disproportionate amount of substance use disorder in American population, but people also perceive that they need help and want it, and I think we often only hear about that amount of people that's disproportionately affected, but a lot of people who are struggling with substances are also looking for help, and I think we don't talk enough about how actually, like, in this population, there's a higher rate of remaining abstinent and sober for people that do seek care. So it's important to make sure we're offering that to folks. And I just want to highlight, like, among people who are getting treatment, it's predominantly in the outpatient setting. So, of the 12.8 million people with substance use disorder who are getting treatment, almost 10 million of those are getting it in an outpatient setting, which is where you all come in and why I want to talk about this today, because this can happen, in any of our clinics. So I think people often worry that they're going to be overwhelmed if they start, providing this kind of care. But it's really, like, extremely rewarding and is not, more time consuming than any other chronic disease management. So I hope I can convey that today. I made a lot of my slides using Chat GPT, which I just sort of do as an experiment to find all of the sort of weird things that they've been missing. So maybe you can point out some of those. I want to highlight the importance of harm reduction. I think in the past, maybe 20 years ago or whatever, people saw this as sort of a fringe idea of offering needle exchanges or some of the other interventions that maybe you've heard about. But I think pretty much everyone who's working in this realm really understands that harm reduction is not a fringe idea. The White House drug czar, has made statements saying, we can't treat dead people. So the idea of making sure that we're meeting patients where they're at, helping them stay healthy, even if they're not ready to stop the substance they're using, is really important. And there's a lot of what I'm going to talk about today that doesn't necessarily mean that people are completely sober, but it's a discussion that we're having with people to help them get to that point if they're interested. So probably many of you are familiar with this idea of screening, brief intervention, referral for treatment, the SBIRT. Pretty much every system's, pushing this as something that's important, metric to make sure that we're tracking. I've always had a little bit of a hard time with this because I feel like it's a box you check, but it actually doesn't have a really great patient-oriented outcome, in my opinion. Like, if you screened and referred for treatment, you're done. But that referral for treatment often doesn't exist. And so, in a perfect world, someone's coming to primary care and the substance use clinic is next door. But the reality is, they leave primary care with a piece of paper and don't actually end up getting the services they need. So I just want to encourage you to consider cutting out the middleman, screen the patient, and have the intervention in clinic being treatment that day, or whatever the patient is interested in. That being said, you should have some system for screening for substance use disorders in primary care. For all adults, it's a recommendation by the USPSTF. There's many different screening tools out there. I'm not going to talk about them all, but there's a link at the bottom of the slide where you can look at them. And if your system doesn't have one, it's important to figure out what might be best for your system and how to start doing this, because you'll find patients who are coming in for hypertension treatment or whatever, who actually are, like, really significantly struggling with substances that you maybe wouldn't have talked about because they felt embarrassed or guilty. We know people often exaggerate or under exaggerate their use of substances in clinic. And so this kind of gives us an opportunity to quantify what the use might be up front. So I'm going to move on to just talking about different substance use disorders. And I want to start with opioid use disorder because I think it's one of the most satisfying diseases to treat. At least it has been for me. I'm sort of like, I love where I work now, but treating alcohol is a different beast. It's way harder. And, starting people on medications that help with opioid use disorder is really rewarding. I'm only putting the DSM-5 criteria for opioid use disorder on this slide and not for the subsequent diseases because it's basically the same. But the main thing I want to highlight is that this might be an option for a lot of patients who are getting chronic opioids for pain management. And if you start asking the questions of some of these criteria, many people do qualify to have an opioid use disorder. Anyone who has tolerance and withdrawal when you stop the meds, that's not enough if they're being prescribed medications because that would happen to anyone. But any one other of these criteria would have someone qualify. And so then you can start the discussion about maybe switching them to a medication that would help them, or at least like having additional options if they're not doing well. And chronic pain management with opioids is a whole different discussion, but just something to consider. So what's available? Methadone, is an older treatment. It's a full agonist therapy. We can't prescribe it in clinic. It's limited to methadone treatment programs. I think in the era of buprenorphine, which is what I'm going to focus mostly on today, there's a very limited patient population that benefits from methadone, just given like how difficult it is to obtain and the restrictions around it. But I do think there is a small patient population who doesn't thrive or who does thrive with a lot of structure and can't handle as less frequent touches that are required sometimes with buprenorphine Suboxone. Naltrexone is an option for certain patients. Again, I don't think it's the best for most patients. It's a straight antagonist, so it blocks opioids. When people can get to the point where they can initiate, which is a full week of being off opioids, which is really hard for people who are regular users, it's as effective as buprenorphine. But in my experience, it's been very rare that I can find a patient who qualifies. The caveat being someone who's been in a treatment program or been in jail or prison who comes out sober. But especially in the era of fentanyl use, this is hard to find opportunities for. And then buprenorphine or Suboxone is a partial agonist. It's a very low barrier to start. We'll get into some of the details of how to do that. But it is one of the most effective interventions for any disease. The number needed to treat to keep people on buprenorphine is 2 compared to placebo. And when you compare this to other medications, that we use routinely, like statins to prevent MIs or aspirin for secondary prevention post-MI, I mean, those numbers are way, way higher. And this is extremely effective. So I encourage people to consider it. And I hope the take home today will be, you can do this in clinic. I recently read this article in The Atlantic and I loved this quote, and it had been kind of sticking with me because I think this is how patients feel. Buprenorphine is effective, which doesn't just mean preventing death, which on its own is pretty awesome, but Suboxone erases need. It allows patients to swap the destructive cycle of addiction with the super boring cycles of routine living. It doesn't just prevent death, it fosters life. And that's really been my experience. Patients are able to get on these medications and they feel awesome and they feel normal. And that's a lot of people's experience when they, can actually chronically get on it. There's a bunch of different formulations of buprenorphine. The one, probably most people are familiar with is Suboxone, and I'll get into the details of why that's different than other formulations. It really doesn't matter practically in terms of the oral doses. There's some other long-acting buprenorphine options. We use that every now and then here. There's a monthly injection, but it's actually, I find patients like taking something every day to kind of remind themselves that they're sober, or to maybe, kind of replace their cycle of use in the past. So a lot of great things about this drug. As I mentioned, like just to stay in treatment and reduce illicit drug use, the number needed to treat is 2. There's a particular a dose point at which that becomes more effective, and we'll talk a little bit about that. It decreases all-cause mortality with a number needed to treat of 3, and at all doses, a number needed to treat of 4 to improve retention. So no matter what dose you're on, you stay in treatment at least, and maybe have some outside illicit use. It doesn't require complete opiate cessation prior to starting treatment, so we can work with people to kind of titrate off their drug of choice more easily. And then there's a much lower risk, and I would argue for buprenorphine alone, actually almost 0 risk of overdose compared to methadone, which is, has a lot of issues with, obviously you could overdose on it, it causes QT prolongation and has a lot of med interactions, and it's just inconvenient for people. So buprenorphine is very safe. They've proven this in kind of lab testing with patients. You give people an equivalent amount of buprenorphine as compared to fentanyl, and there is a plateau effect at which point people will no longer have respiratory depression. So on its own, there's something about the way this drug works that it doesn't cause the respiratory depression that other opioids do, which is really great because we don't have to worry that patients are going to go home and take a bunch of it, which I'll tell you in my experience, people aren't trying to just like take a bunch of their buprenorphine. They want it to get help and feel better. I think that it can be very confusing that there are different formulations and that Suboxone is the most common one. This is basically just a combo formulation that was developed in an attempt to decrease abuse. And so the naloxone component is an inert part of the drug when it's taken properly. There's practically no difference between taking Suboxone and buprenorphine only when it's taken correctly. So buprenorphine is the active ingredient. When this drug is taken sublingually, it blocks the use of other opioids. So when people use on top of it, they don't get a euphoric effect, and it also can be protective in preventing overdose. So where I worked before, we're kind of just giving buprenorphine to anyone who was using opioids to try to help them get off, and found that, of the many people we gave it to, we weren't seeing overdoses. And I think, people were taking it even intermittently. It was helping protect them. And buprenorphine is interesting in that it has the highest affinity of opioids for mu receptors. So it can cause precipitated withdrawal when other opioids are present. I think there's a lot of misconception about what actually causes the precipitated withdrawal. It's not the naloxone when it's taken properly. But if someone does try to snort or shoot or take this drug not like it's intended, the idea is that they will get sick from the naloxone component. And I think practically, I don't see patients trying to abuse buprenorphine. If people are buying it or selling it, it's to fill in a gap in access. So it was very rare that I met a patient, and I've probably seen thousands of people who are prescribed this medication. It was very rare that someone was trying to do something illegal with, or whatever, abuse it. So just to clarify, because people I think can get confused about this, the precipitated withdrawal is caused because the buprenorphine, which is the middle graphic there, has a higher affinity for the receptor, so it will kick off anything that's already there. So when a patient's taking another opioid and then they take buprenorphine, their relative experience will be that of withdrawal. They're not fully blocked, like as if they took naloxone or naltrexone, but relative to what they were taking before, they'll feel sick. So it'll be experienced as withdrawal. People aren't going to die from this. It's not inherently dangerous, but I think you want to avoid it to help people have the best experience they can to want to continue this treatment. So the dose ranging, I think, also can be confusing because there's the 8/2 milligram or 2/0.5, whatever it is on the Suboxone. You basically just ignore the naloxone component. The tabs and films come in 2, 4, 8 milligram formulations. The average dose range I find is about 8 to 16 milligrams, but they're very patient dependent, and it's not. I haven't found it is equal to how much the person was using of their opioid of choice prior to me starting them. But as I mentioned before, doses of 8 to 16 milligrams are effective in treatment retention, but greater than 16 milligram doses are effective in reducing illicit drug use and have improved mortality. Until about maybe 2 or 3 years ago, when I would give this talk, I would say if patients were using more than or feeling like they needed more than 24 milligrams, then I would consider, maybe they were selling it or doing something else with it. But there's been some recent data showing that probably some patients need 32 milligrams. And at that point, there's not a lot more bang for your buck, because of the ceiling effect of this drug. At some point it will it will fill all the mu receptors, and you won't have any more effect. But I do have a few patients on that higher dose, and I found it's been helpful for them and helpful to keep them in treatment. So just consider that if people are asking or you've seen this. So to start this in clinic, first, obviously, you want to make sure the person has a diagnosis of opioid use disorder. You want to do a little history about if other substances are being used. When I first learned about Suboxone, there was sort of a hard stop on people who were using alcohol or benzodiazepines, but both the FDA and multiple organizations have come out to say, like, obviously using alcohol and benzos in the context of buprenorphine is safer than using them in the context of fentanyl or heroin or some other illegal opiate. So it's definitely not a reason to withhold buprenorphine, but an opportunity to talk about how to address those other substances. Always important to get a pregnancy test on females. It doesn't mean you would do anything differently necessarily, but it's obviously an opportunity to check for this. But also, for a while, we were only using the buprenorphine monoproduct rather than Suboxone. I don't know that it matters at this point, but if you have a pregnant patient, it's a little more complicated, and I probably would just stick to that monoproduct because that's what the main studies have been done in pregnant patients. But anyway, you want to know if they're pregnant, obviously. And then I don't know that it's that helpful to do a urine drug screen on the first visit. If there's some question about whether someone recently used or they're using other stuff, it can be helpful. But I find a lot of patients just want to feel better. So if they can't pee or there's some issue, I don't push it. It doesn't matter that much to me. I think it's important to just ask, where people have received treatment before, what their experience has been, so you can kind of figure out what dose range was good for them. A lot of people have, had this treatment in the past, and we'll be able to tell you what worked for them. If you can, it's important to review a PMP just to make sure that the patient's not, getting it from somewhere else, or there's something that is complicated. But if you're prescribing opioids, you're doing this for patients routinely. I don't know that it matters that much to the treatment using buprenorphine, but it's certainly good to review past medical history, psych history. People have comorbid psychiatric disorders, then number one, it can be an opportunity to address those if they've been out of care. But number two, just it might be a little more complicated to help patients manage some of the initial withdrawal they'll feel until they can get on the Suboxone. And then again, a good opportunity to screen for communicable diseases. And then I just always make sure that at the end of when I've already talking about this stuff, review what patients are using and make it clear that it's important that they're honest with me so that I can help them, feel the best with this treatment. And so, because if they really just used an hour ago and they told me it was 12, that's going to be a difference in how they experience this. When I first learned about this, there was a lot of talk of induction. It sounded like this complicated process, but I mean, really, we're just starting patients on this medication. But I think sometimes people think they have to check a COWS, which is this clinical opiate withdrawal scale score, and if they're not elevated, they can't start the medication. But this score was really developed for a research setting. Practically these days, if the patient's in withdrawal, we can do this score, and if it's elevated, then we know they are. But if they're not, it doesn't mean we're not going to start the medicine today. We'll just do it at home. So I don't routinely check this unless the patient looks terrible, or they're telling me they're in withdrawal and they don't look like they are. So just one less thing that you have to do. It's pretty normal to do the home induction these days. Again, early on, people were saying you should start the medicine in clinic in case the person has precipitated withdrawal, but I don't think there's any reason for that, and most of us aren't doing that anymore. It's like an extra barrier for patients to both require them to come to clinic feeling terrible and then wait there for hours until they get the med and receive it. So if they're in active withdrawal, or they aren't and they haven't used in the last few days, you can give them, they can take the dose immediately, but again, I don't do it in clinic. And this is kind of how I do it for patients. you can start a little lower, but I've found that when people feel sick, they want to feel better sooner. So I usually tell them to take 4 to 8 milligrams initially, and then take 4 milligrams every 4 to 6 hours, up to 16 milligrams the first day. And then the next day, take an 8 milligram dose in the morning and repeat it later if they need. And then the third day, just take what you were taking on day 2. And then the second scenario, which is more common, is that patients come to the clinic, they're not in withdrawal or detox. And so you just kind of have to talk to people about how they do this at home. And it's pretty simple. Like, people know when they are in withdrawal or feel sick. So I just tell patients, when, ideally you wait 12 hours since you've used a short-acting opioid. But when you start feeling sick, wait another hour or two and then take your medicine. Rarely patients don't listen to me and they take it and they feel sick and they say, oh, I should have waited. But I don't find people are upset. In general, for heroin or other short-acting pills, I tell people to wait at least 12 hours. But again, it's more like symptom based. For longer acting pills, usually a full 24 to 36 hours is ideal. And then fentanyl is complicated. If people aren't using a lot, it's short acting, so it probably falls into the 8 to 12 hour range, but people have been using for a long time. The fentanyl builds up in their system, and so it can actually take days for people to be able to start. And we'll talk about that scenario in a minute. And then if people are on methadone, these probably aren't the patients to treat in clinic. It's complicated to help people transition, and I would seek a referral for this. But kind of same thing. I just tell people, when you feel sick, take 4 milligrams. If you feel better, take another 4 milligrams, and then just keep doing it up to 16 milligrams in the day 1, and then kind of same for the next couple of days. And if people do feel sick, and they do develop precipitated withdrawal, the treatment is just to keep taking the Suboxone until they feel better, which is basically the same thing we're telling them to do, because they just need to overwhelm the mu receptors and kick off all the other opioids. And so sometimes I'll give people kind of supportive meds to help with that. So there's a lot of different microdosing schedules, and you can just Google it if you're interested. But basically, you can cut the strips or tabs into tiny, tiny little microdoses and titrate up in people that are actively using. And so they can kind of lower their illicit use, increase their buprenorphine until they're at a point where they're completely off. Generally fentanyl is the drug. If you have access to a transdermal buprenorphine med, those are really low doses and they're great, but and you can just put one on while someone's still actively using, but they're generally not covered by insurance, and I haven't found that I've had great access to them. And then what to do with urine drug screens. This is often part of the treatment plan, and it's an important one, but I always make sure I tell patients, this is part of how I can help make sure that you're doing well with this medication. It's not punitive. I'm not going to stop your medicine. And unlike with other, chronic pain managements with opioids, I'm not stopping the person's Suboxone because they're using opioids, but maybe my dose is inadequate. Maybe they're having trouble transitioning. It's a good opportunity to talk to people about it. And then, back to harm reduction, if people are still using or using other drugs, we treat it like any other chronic disease. We don't stop Lasix in patients that are eating a lot of salt, or stop insulin in diabetics who aren't, taking it regularly or not having a diet that we'd like them to. So I think it's important to kind of transition to thinking about this disease like any other chronic disease. So what does my follow-up in clinic look like? I try to see patients that are initially started on Suboxone, buprenorphine, every 1 to 2 weeks, the first 1 to 2 months, but these can be phone check-ins. So I usually have them come back in a week, and then after that can be a few weeks. But they should be, seen monthly or so for the first 3 to 6 months, and then you can really start spacing that out when people are stable and doing well. There's early on a lot of talk about requiring people to have counseling associated with buprenorphine prescribing, but you can do this in the office. And also the data shows that basically being on this medication is effective without additional counseling. So I don't, if people want it, that's great, but I don't think it's necessary. People really tend to do well once they're sober on buprenorphine. And you can consider other additional programs. And then often I'll use, other resources in clinic to check in with patients, ask my clinic nurse or other folks just to call and see how they're doing. And so that's definitely like a way that you can help field some of the patient's needs or check in with them. And the other thing I realized I didn't put on this at all is, you used to have a special waiver for buprenorphine, but hopefully everyone's aware you don't need to have that anymore. Anyone can prescribe this. And, if you want additional training beyond today, talking about, how to prescribe buprenorphine, there are options for that, but it's available for anyone to prescribe these days. Okay, so where I work, I do a lot of prescribing of medications for alcohol use disorder. I think this is like a really important thing to offer people. Alcohol is so prevalent. The mainstay of what I'm doing, and I think like what is mostly done is prescribing naltrexone for people. The idea is naltrexone blocks the cycle of craving for alcohol, and it's pretty effective. It's not a magic drug like I think buprenorphine is. The number needed to treat to reduce total drinking days and drinks per day, and heavy drinking days in a month is 12, and increasing abstinence rates, percentage of days abstinence, length of continuous abstinence, it's 20, but still pretty good. And I think it's not that common to consider this for people who are telling you they're using alcohol, especially heavily or in an unhealthy way. But I pretty much offer it to anyone who's, is talking to me about having concerns about their alcohol use. There is a long-acting version of naltrexone. We actually haven't had the tablets in stock for like 6 or 7 months, so I'm pretty much giving everyone this long-acting. And what I find is when I prescribe the tablets, people just stop taking them if they're going to drink. But what's nice about the Vivitrol, the long-acting, is, people already have it in their system, so at least they're not stopping it if they're going to be drinking. And it's been found that it's maybe a little more effective in reduction of heavy drinking days, and people come back more frequently. And there's no reason people can't take these meds when they're drinking. And again, it like comes back to harm reduction. It's like if you're going to help people reduce their total drinking days in a month, that's a win for them. They're feeling better. They're benefiting from it. Couple side effects, mostly nausea and headaches are the main things that people describe. A very small amount of people have a flu-like syndrome. I've maybe seen this once, but the nausea and headaches, do happen about 5% to 10% of the time, and they resolve after a few days. If you're going to be prescribing this, it's just really important to make sure, obviously, people aren't using opioids at the same time. The main contraindication is, if you look up naltrexone, is that it can cause increase in liver function tests. But there's no correlation between this and drug-induced liver injury. So I think these are based on like old case reports. And I've talked to big time national experts in hepatology and addiction, and they're pretty much giving it to anyone, regardless of LFTs or their cirrhosis status. Practically, I do the same thing here. If people are in a situation where their liver function tests are 600, 700, and that's new, and they were just in the ER, then I'm not going to do it because I don't want to cloud the picture of what's going on with their LFTs. But I think if people are looking for treatment and this is a really great drug, then we should offer it as much as we can, knowing that like pharmacologically it's safe. It's not recommended in pregnancy, mostly because there haven't been studies that have been done, and I've done it a few times in people that are like actively drinking. I don't think there's any like known harm to the fetus. It's just there's not a lot of data, and it's obviously better for people to not be drinking when they're pregnant. So again, like kind of harm reduction. The thing that's nice about the pill is when people are taking it daily, it's maintaining a steady state in their system, whereas the shot really tapers off towards the end of the month. But again, you kind of have to decide if people are going to likely take it every day, because if you're not, then it's, zero. The serum concentration is zero, and so it's not doing anything. So I tend to use the shot when I can, and it's all we have in stock right now. The other medication that has been shown to be pretty effective is acamprosate. So this is a glutamate modulator that depresses an NMDA receptor activation. Beyond that, it's not really known why it's super helpful to decrease alcohol use. It's most effective in patients that are in a period of abstinence, so it's not so great for people that are actively drinking, but the number needed to treat is pretty good, 12 to prevent return to heavy drinking. It's a very annoying dosing schedule. It's 2 pills 3 times a day, so that's pretty hard for people to be compliant with, but it's very well tolerated. The only contraindication is when people have severe renal dysfunction, but I do use this from time to time in people who don't want naltrexone or have some reason why they've had a bad experience in the past. Other treatment options. The main one here that I wanted to highlight, well, two, I use a lot of gabapentin, mostly there's data that shows that it's probably about as effective for management of mild and moderate alcohol withdrawal as benzos, but there's in those studies where they were using it, people had a reduction in drinks consumed and a prolonged time to return to drinking when they were on gabapentin for a few months after withdrawal. So I do use it to help people after they have gone through a period of withdrawal, which is fairly common in the folks that I'm seeing. I try not to continue it forever because it obviously has its own issues. But if you're going to do that, the dose that has found to be most effective is 600 milligrams TID. And again, it's a three times a day drug, so it's tricky for people. Disulfiram or antabuse basically isn't effective unless it's administered to the patient, because people just stop taking it because it makes them sick. Topiramate has some good data, but it's pretty limited by the side effect profile, so I don't really use it. And then there's lots of other options to refer patients to non-medication programs that are not medication based. I will say, some of my patients really find AA helpful, but the data on it, which there isn't a lot despite its being around for decades, is it's probably only effective in about 10% of people who use it on its own. So I really try to make sure I'm offering something else to patients to help be an adjunct to that. Probably the second most common drug we see here is methamphetamine. If folks haven't seen this and are interested, there's a great book by this guy, Sam Quinones, that wrote Dreamland, kind of talking about the rise of what's called P2P meth in the last 5 years or so. It used to be made from Sudafed and byproducts of that, but now it's just made from whatever. That's why it's so hard to get a handle on the import of meth and making of meth. It's just a lot of dangerous chemicals, and so it has a lot of really bad side effects, which if you've managed anyone who's actively using meth, it's tricky. There aren't any FDA-approved treatments for amphetamine-type substance use disorder. There are a few drugs that can be helpful, but definitely fewer than opioids and alcohol. The main one I go to is a combination of bupropion or Wellbutrin and IM naltrexone. This has been the most effective medication-assisted treatment for meth to date. Reduces cravings and use, and the number you treat is pretty good. It's 9. But I find that the bupropion dosing they did in the study where they looked at this, it's pretty prohibitive for people. It was 450 milligrams daily, and people get a lot of side effects from that. So I haven't found it to be as magical as that the study shows, but it's something that I try. There's some decent data on mirtazapine, reducing use. Again, I haven't found it to be super helpful. ASAM, American Society of Addiction Medicine, just put out its guidelines on treatment of substance stimulant type use disorder. And in the past, I haven't really that often put people on prescribed stimulants, but they do say it's something you can try. The data for it's not great, unfortunately, but something to consider specifically with methylphenidate. And really the mainstay of treatment is behavioral interventions, particularly something called contingency management, which is basically paying people some nominal amount to stay sober, and that's been found to be the most effective. But there's not a lot of programs that offer that. And then the main thing that I often help people with is like if they're using meth, a lot of times people are dealing with psychosis, poor sleep, paranoia, and so I do a lot of prescribing of antipsychotics for people to help manage those symptoms. But it's hard. I think people do need a treatment program to help get away from the drug and get some support to stay sober. Is that study I mentioned? So again, the number needed to treat was 9 with this combination. There was a statistically significant response to treatment, but the overall percentage of people who responded was only 13.6%. So, it wasn't effective in that many people, but compared to placebo, it was much more effective. And the last thing I'll talk about second to last thing is medication-assisted treatment for tobacco use. This is something probably a lot of people are familiar with. I just want to highlight mostly that I think we're probably underutilizing varenicline. It's the most effective treatment. There was this FDA concern about psychiatric side effects, but that's basically been refuted. So I think this is a great drug. I offer it to anyone who's smoking if they're interested. The data shows it's probably best when it's combined with nicotine replacement. So I try to offer those both up front. Bupropion, similar to what I mentioned with meth, it's limited by its side effect profile and only modestly effective alone. But it can be helpful if it's combined with Chantix or varenicline. And then the last thing I just want to mention, I see so much cannabis use, and I was just talking to one of my colleagues about, if I thought it was harmful. And 10 years ago, I might have said no, but the THC levels in cannabis, like when people are smoking it, are probably 5 to 6 times higher than they were 25 years ago, just because it's now so commercially developed. And some of these concentrated products, like when people are dabbing or smoking, the concentrated resins are as high as 90% THC. So I think there's a lot of negative health effects of these really high doses of THC that maybe you're seeing, like people who have hyperemesis, cannabinoid associated hyperemesis, or psychological disorders. There's association with psychosis in teenagers. So I have been a little more aggressive about talking to people about this. Psychosocial interventions are the cornerstone of treatment for adolescents. Just even talking to them about it in the office has been shown to be beneficial. But really, CBT, MI, talking to people through kind of how to change their use is probably the most helpful. There's a couple studies looking at gabapentin and reducing cravings and withdrawal in adults. So sometimes I'll try that in people who are really trying to quit and struggling with the side effects of cessation. And then N-acetylcysteine, which is basically a vitamin, has been shown to be effective in small trials with adolescents. So sometimes I'll offer that. One time I've used dronabinol to help manage some severe withdrawal, but I don't routinely use that. And then there's some data for quetiapine for withdrawal symptoms. Really quickly, because I'm running out of time, I just want to talk about what we were doing at IHS, at White River IHS. So we developed this bridge clinic where patients get referred to have dedicated substance use treatment. We've been giving IM naltrexone routinely in the ER and on our inpatient unit, starting people on buprenorphine in the ER when we see folks that need it. And then we just hired 2 substance use navigators, which are life-changing for us in the ER and our patients who see patients and basically act like dedicated social workers for substance use. And this is all kind of a lot of what we're doing is through this bridge program that started in California. And there's a website there. I have a lot of amazing resources. I encourage anyone to just check it out. So there we go. I will see if there's any time for questions. Sorry.
We do, if you open up the chat, you can see some of the
Yep.
questions.
Cool.
The first one is from Amelia, who's originally from Finland. Do you see that question?
Yep. Yeah, I mean, we don't have Subutex as available, um, and so I feel like the like opportunity for people to abuse it is maybe less so. I will say I've been a little like cautious in the population I work with because sometimes people ask me for buprenorphine and they have no history of opioid use disorder, and they're like in jail or in a treatment program, and so I don't want to help them. I don't want to like put them on a medicine that um, is not treating a disease they have. So I'll often put those folks on naltrexone. Um, but I don't find that buprenorphine has been like a drug of choice of abuse here. And there's actually quite a few papers showing that people who are abusing it or people who are acquiring it illegally are doing so because they want help with treatment. So I don't know. I haven't seen that.
Okay, and then there's
Um,
next question, is there, can we get more putting in here? It keeps moving. Okay, is there a suggested age limit to receiving this type of medication, like regulation by the healthcare facilities?
um, so for each drug, it would be different. The data on buprenorphine in teenagers is actually a little different than adults, so I should have clarified that. Basically for adults, like stay on it your whole life, this will help you stay healthy and sober. For teenagers, obviously you have to get parental consent to start this medication, but then probably in 6 to 10 months you can taper kids off of it pretty quickly, so it's a little different in that way. Um, but there's not like any healthcare facility regulation. I think I would probably base like what I do on the studies, and there's just much fewer studies in medication assisted treatment for the various different disorders in teenagers. So like every now and then I'll use naltrexone for teenagers or adolescents, but mostly, kids haven't their brains are still malleable. There's a lot of like behavioral interventions that can be done. So I don't do it as much unless there's like, no other options.
Okay.
Um,
And the third question, you see that? What do people report about how they feel about drinking when you give them treatment with
naltrexone.
naltrexone
Yeah.
for AUD? Yeah. And what is the average length of treatment with it for AUD?
So it's interesting. They don't feel sick. There's no report of that. But definitely people tell me, uh, gosh, I went out and normally I would drink 10 drinks. I started drinking and I had two, and I just didn't really want anymore. That's not everyone. And I think, we really broadly give this medicine to people in the ED. And I think we probably aren't as selective as we should because, someone who's drinking a liter of hard alcohol a day every day who is like fairly pre-contemplative is probably not going to benefit as much from it as a person who's um, coming in really interested in like helping stay sober and is having, struggling. So that effect isn't as dramatic as I'd like to be with everyone, but for the patients that benefit, that is what they report. And then the average length of treatment, um, I usually start talking to people about uh, considering not doing it after a year. I really feel like that year period is like essential for people to experience life sober because there's so many things that they've been avoiding, so many feelings and emotions that are coming up, like mental health issues they didn't realize. But if you look up like what the recommendation is, do it for life. It's not harmful if it's beneficial. But what I find is people start feeling better, and then they either don't come back or want to stop it, and then have relapse. And that's the nature of treating addiction is dealing with relapses and helping people come back in and talk about it.
Without any judging.
Right,
So they do
exactly.
come back.
Because they feel bad, right? And
Sure.
if you can just say to people like, "Hey, I'm so glad you came back in. That's what I'm here for. We're happy to see you today."
Right.
So
All right, I don't see any other questions in there. And we are right at about 1 o'clock. So everybody, again, thank you for joining us today. The evaluation will be posted it was posted in the early chat. I'm gonna go ahead and just put it down in the chat again one more time. And everybody that connected today, I will be sending out a thank you email with those links and that information. You'll be able to go online and check with the recording, and we will have a copy of Dr. Mega's slides as a PDF for handout that you can take a look at. And then if we have any other questions that come up afterwards, please email me. And Dr. Mega had put his email address on there as well if you had any questions for him. And Ernestine, I see you've come back on. Would you like to say something?
Just thank you to everyone. Thank you, Dr. Megan, and thank you, Melanie.
Absolutely. All right, everybody. So be sure to check our website. I'll have our website to follow up on the next ones. And when we get our next lecture with the AHEC, I will be sure to send it out to everybody that has joined us. And we look forward to seeing you again. Thank you again, everybody, for joining us, and have a great rest of the afternoon.
Thanks, everyone.
All right. Bye-bye.